Before we dive in, let me ask you something. What comes to mind when you hear the word stroke? A lot of people don't realize this, but stroke is one of the most time-critical emergencies we deal with in healthcare. When a stroke happens, every second counts. Neurons are dying, brain tissue is at risk, and the window to intervene is closing fast. That's why rapid recognition isn't optional, it's everything. The faster we identify the signs, the faster we can activate the stroke pathway, get imaging, start treatment, and protect the brain. And here's the part I really want you to hear. Nurses are often the first to notice something's wrong. We're the ones at the bedside, in triage, in the room when symptoms start. Our assessment can literally change the outcome. So today, we're breaking down exactly what you need to know. How to recognize a stroke, what to do in those first critical minutes, and how your actions can save brain tissue and lives. Let's start with the basics. What exactly is a stroke? A stroke is a brain attack. It happens when blood flow to part of the brain suddenly stops. And when that happens, brain cells begin to die within minutes. Sometimes it's caused by a clot blocking a vessel. That's called an ischemic stroke. Other times, a blood vessel ruptures and causes bleeding in or around the brain. That's a hemorrhagic stroke. Either way, every second matters. The longer the brain goes without oxygen, the more damage occurs. That's why stroke is a true medical emergency. Recognizing the signs early and acting fast can save lives and prevent lifelong disability. Because in stroke care, we say it all the time. Time lost is brain lost. The Rapid Recognition and Nursing Priorities Quick Guide centers on immediate stroke identification and critical nursing actions that prevent irreversible neurological damage. All right, let's start with the very first thing you would do when you suspect a stroke, the initial assessment. This part happens fast, but it's where nurses make the biggest difference. First, the moment you walk into the room, you make your assessment, you check the ABCs: airway, breathing, circulation. If those aren't stable, nothing else matters. You fix that first before anything stroke-related. Next thing, glucose. Always. Hypoglycemia can look exactly like a stroke, so a quick finger stick saves you from going down the wrong path. Once you know they're stable and not hypoglycemic, you jump into a rapid neuroassessment. If you're NIHSS trained, great, use it. If not, you're still looking for the big red flags. Facial droop, arm drift, slurred speech, sudden weakness, confusion, anything that feels off. And then you ask the most important question. When was the last time they were seen normal? Not when symptoms were noticed, when they were normal. That timestamp determines everything. TPA thrombectomy, the whole treatment plan. And once you have enough suspicion, I don't wait. I activate the stroke alert. Because the faster you move, the better the outcome. Time is brain, and nurses are the ones who start the chain reaction that saves it. Time is brain. Every minute counts in stroke care. Every minute counts. Every second matters. Every minute 2 million brain cells die during stroke. When we talk about stroke care, we're not just talking about symptoms. We're talking about saving brain tissue. All right, let's move into one of the most important parts of stroke care, the neurological assessment. If you've ever heard of the NIHSS, this is where it comes in. NIHSS stands for National Institutes of Health Stroke Scale. The NIH Stroke Scale is our standardized way of measuring how severe a stroke is. It looks at things like level of consciousness, gaze and vision, facial droop, motor strength, speech, and neglect. Basically, it gives us a snapshot of how the brain is functioning in real time, helps quantify stroke severity and track changes. The NIHSS Severity Guide is a quick reference tool that helps clinicians interpret stroke severity based on a patient's NIH stroke scale, NIHSS score. The NIHSS itself measures neurological deficits across 11 domains, including level of consciousness, gaze, vision, facial palsy, motor strength, speech, and neglect, producing a total score that quantifies how severely the brain is affected. And the scoring matters. 0 means no stroke. 1 to 4 is minor, 5 to 15 is moderate, 16 to 20 is moderate to severe. Anything above 20, that's a severe stroke. Repeating the NIHSS every 1 to 4 hours is a core nursing responsibility in acute stroke care because it helps you catch even subtle neurological changes early. And those changes can completely alter the patient's treatment plan. What I love about the NIHSS is that it keeps everyone on the same page. Whether you're in the ED, ICU, or handing off to neuro, the score tells the team exactly what they're dealing with. And here's the key. We don't just do it once, we repeat it. every hour to every 4 hours, depending on the protocol, because changes in that score tell us if the patient is improving or deteriorating. A rising score can mean worsening edema, bleeding, or new ischemia. A dropping score? That's what we want. It means the brain is recovering. So whether you're NIHSS certified or still learning, remember this. The neuro assessment isn't just a checklist, it's a language. And when we speak it clearly, we give our patients the best chance at recovery. How to recognize a stroke fast. This is one of those moments where your assessment can literally change the outcome. So FAST stands for facial droop, arm weakness, speech difficulty, and time. I feel like people hear about FAST all the time, but they don't always understand how quickly these symptoms show up. Strokes don't warm up. They hit suddenly, and every minute counts. So let's walk through FAST together, and I'll show you how we use it clinically, not just in the community. All right, let's start with F, facial droop. Ask the patient to smile. If one side doesn't move or looks uneven, that's a major red flag. Even subtle asymmetry matters. And here's the thing. Patients don't always notice it themselves. You have to look closely. Next is A, arm weakness. Have the patient lift both arms straight out. If one arm drifts down, can't lift, or feels heavy, that's concerning. And again, subtle weakness still matters. Don't wait for complete paralysis. I've seen patients who say, "Oh, it's just a little numb," and it turns out to be a stroke. Patients often minimize symptoms. Our job is to recognize what they can't see. Now S, speech difficulty. This one is huge. You're listening for slurred speech, trouble finding words, mixing up words, or saying things that don't make sense. Even if they can talk, but something feels off, trust your assessment. Sometimes they're aware something is wrong, and sometimes they're not. Aphasia can be incredibly frustrating for patients. They may know what they want to say, but can't get the words out. Or they think they're speaking normally, but they're not. Either way, sudden speech changes are a major warning sign. And then T, time. Yes, time to activate your stroke protocol. Not wait and see. Not, let's give it a minute. The clock starts the moment symptoms appear. This is where the time is brain principle becomes real. So what does that look like in practice? It means you call your stroke alert. You get the patient to CT as fast as possible. You notify the provider. You document the last known well time. You move with purpose. Because the sooner we identify the type of stroke, the sooner we can treat it, whether that's thrombolytics, thrombectomy, or supportive care. And delays can change everything. Every minute counts. Early recognition is what gets patients evaluated faster and improves outcomes. All right, next is the critical stroke assessment questions. Let's walk through the exact questions you should be asking the moment a stroke is suspected. These aren't random. They're evidence-based, time-sensitive, and they guide everything that happens next. Purpose is to identify onset, risk factors, and contraindications before initiating stroke protocol or thrombolytic therapy. Okay, first question, and this one is huge. When was the patient last known well? This is the timestamp that determines eligibility for interventions like TPA or thrombectomy. We care about the last moment they were normal. If they woke up with symptoms, that's a wake-up stroke, and the timeline changes. Next, what symptoms started first? This helps us understand the progression and whether we're dealing with a true stroke or a mimic, like hypoglycemia or a seizure post-ictal state. Stroke mimics can look identical at first glance, so this question matters. Then we ask, any blood thinners or anticoagulants? Because if they're on something like warfarin, DOACs, or even heavy aspirin use, that changes our risk profile. So that affects whether they can get TPA. Safety first, always. Next up, history of stroke or bleeding disorders. We need to know if there's a higher risk of hemorrhage or complications. Then, any recent surgery or trauma? Because fresh surgical sites or injuries can make clot-busting medications dangerous. And finally, any severe headache? A sudden, intense headache can point toward hemorrhagic stroke instead of ischemic. So these questions basically help us separate ischemic from hemorrhagic risk. These questions help us decide whether to activate stroke protocol, call neurology, or prepare for imaging. These questions guide safe, evidence-based decision-making, distinguishing ischemic from hemorrhagic risk, and determining eligibility for interventions like TPA or thrombectomy. These questions are fast, but they're powerful. So remember, stroke care is a race against time, but it's also a race for accuracy. These questions help you deliver safe, evidence-based care every single time. All right, let's discuss with our immediate nursing actions. We're breaking down one of the most critical moments in emergency nursing, the first 20 minutes of patient care when a stroke is suspected. These early actions set the tone for everything that follows, and as nurses, we're often the ones driving that momentum. Let's walk through the essential steps and talk about why each one matters. First up, a non-contrast CT scan within 20 minutes. This is the make or break moment. We need to know whether we're dealing with an ischemic stroke or a hemorrhagic stroke, because every treatment decision depends on that distinction. Our job is to recognize the urgency, coordinate quickly, and make sure that patient gets to imaging without delay. Next, IV access, ideally 2 lines. One line for fluids or medications, and the second as a backup for labs, contrast if needed later, or rapid interventions. It's all about staying ahead of the curve. Then we move into drawing labs, CBC, CMP, PT/INR, and troponin. These give us a snapshot of the patient's baseline, their clotting status, and any cardiac involvement. It's not just checking boxes, it's building the clinical picture in real time. We also place the patient on a cardiac monitor. Stroke and cardiac issues often go hand in hand, and rhythm changes can give us important clues. Continuous monitoring keeps us alert to anything that shifts. Another key step, maintaining NPO until a swallow screen is completed. This is huge for patient safety. Dysphagia is common after stroke, and even a small sip of water can lead to aspiration. We use tools like the 3-ounce water test and watch for coughing, throat clearing, or changes in vocal quality. And finally, obtaining a 12-lead ECG. We're looking for arrhythmias like atrial fibrillation, which is a major cause of embolic strokes. Early detection helps guide treatment and prevents future events. So when you put all of this together, these steps aren't just tasks. They're a coordinated response aimed at stabilizing the patient, gathering critical data, and preparing the team for rapid decision-making. This is where nursing leadership shines. All right, let's talk about one of the most time-critical interventions in stroke care, thrombolytics, specifically TPA or TNK. These are powerful medications designed to dissolve clots that block blood flow to the brain during an ischemic stroke. And timing is everything. The general window for administration is within 4.5 hours from symptom onset. That's why rapid assessment and decision-making are crucial. Once the infusion starts, nurses play a huge role. We monitor closely for any signs of bleeding at IV sites, gums, urine, or stool, and perform frequent neurochecks. The schedule usually goes every 15 minutes for the first hour, every 30 minutes for the next 6 hours, and then hourly until 24 hours post-infusion. And we avoid invasive procedures after giving TPA. No new IVs, no Foley catheters, because the risk of bleeding is high. And we avoid invasive procedures after giving TPA. No new IVs, no Foley catheters, because the risk of bleeding is high. Now let's talk about mechanical thrombectomy, one of the most advanced interventions for ischemic stroke. This is a direct clot retrieval to restore perfusion and minimize infarct size in large vessel occlusion strokes. This procedure is indicated for large vessel occlusion, typically involving the internal carotid or proximal middle cerebral artery. And what's really important is the time window. It can be performed up to 24 hours in select patients, depending on imaging and clinical criteria. Key considerations: if it's not available everywhere, so if your facility doesn't have endovascular capability, the priority is rapid transfer to a comprehensive stroke center. Sometimes it's done after or instead of TPA, depending on eligibility and imaging results. The goal is simple: restore perfusion and minimize infarct size through direct clot retrieval. And nurses are absolutely vital here, coordinating transfer, maintaining hemodynamic stability, and preparing the patient for the procedure. Mechanical thrombectomy represents teamwork at its best: rapid recognition, coordination, and precision care that can truly change outcomes. Now, let's talk about one of the trickiest parts of stroke care: blood pressure management. It's a balancing act. We don't want to lower blood pressure aggressively unless it's specifically ordered. Before TPA, we aim for less than 185/110, and after TPA, we keep it below 180/105. Those numbers are critical for safe thrombolytic administration. And the reason we're cautious is all about preserving cerebral perfusion. During a stroke, the brain's autoregulation is impaired, so higher pressure helps push blood through collateral vessels to the ischemic area. If we drop that pressure too fast, we can actually collapse those fragile vessels and worsen the infarct. Especially in patients with chronic hypertension, their vessels are used to higher pressures. A sudden drop can cause hypoperfusion and make the stroke worse. So the clinical takeaway is simple. Keep blood pressure high enough to sustain perfusion, but controlled enough to prevent hemorrhagic transformation or cardiac strain. Nurses play a huge role here, following the protocol closely, titrating gradually, and communicating any changes immediately. Blood pressure management isn't just numbers, it's about protecting the brain. Sometimes patients come in with facial droop, slurred speech, confusion, or weakness, and everyone's thinking stroke, but not every case is a true stroke. Stroke symptoms come from disrupted brain function, but several conditions can temporarily impair the brain without a vascular blockage or bleed. The result looks the same: facial droop, slurred speech, confusion, but it's actually a stroke mimic. Let's go through the common ones. Here's a common stroke mimics and why they look like stroke. First up, hypoglycemia. Low glucose starves the brain of energy and can cause focal deficits and slurred speech. That's why a fingerstick glucose is one of the first checks. Next, seizure or postictal state, also called Todd's paralysis. After a seizure, one side of the body can be weak for minutes to hours, and speech may be affected. Then there's migraine, especially hemiplegic migraine. The aura can cause weakness, numbness, visual changes, or aphasia, symptoms that evolve over minutes, just like stroke onset. Electrolyte imbalances are another big one. Sodium, calcium, or potassium abnormalities can cause focal deficits or altered mental status. Labs are essential before activating stroke protocols. Nursing priority: draw labs early, BMP or CMP. Correct imbalances before or alongside stroke workup. And finally, brain tumors. Mass effect or edema can mimic stroke symptoms, though they usually progress more gradually. Imaging is key to differentiate. Nursing priority: request urgent CT or MRI imaging monitor for signs of increased intracranial pressure. Distinguishing stroke from a mimic prevents unnecessary TPA administration, delays in treating the actual cause, exposure to bleeding risk, and it ensures true strokes get rapid, appropriate care. Speed matters in stroke care, because every second truly counts. Stroke outcomes depend on how fast we recognize and act. Early intervention can mean the difference between full recovery and lifelong disability. Think of it this way: time equals brain. Every minute of delay means millions of neurons lost. And delay equals disability. Lost time means lost function, speech, movement, independence. But fast action equals better outcomes. When we act quickly, we save brain tissue and give patients the best chance for recovery. So when you see stroke symptoms, don't wait. Activate the stroke pathway immediately. Every second counts. The faster a stroke is recognized and treated, the more brain you save, and the better the chance for recovery. So as we wrap up, remember, stroke care is all about timing. Whether you're at the bedside or in triage, your quick action can change a patient's life. Stay alert, follow your protocols, and trust your training, because every second counts. And that's how we make a difference, one rapid response at a time. Hope you've learned something about stroke, because the more we understand it, the faster we can recognize it, and the more lives we can change. If you like this video, please hit like and subscribe. It helps more people learn how to recognize stroke fast and save lives.